Hello, and thank you for joining us for this webinar. Today, we're going to talk a little bit about imaging the acute abdomen using radiographs. Now, this was a presentation that I originally gave way back in November 2018, and given the current circumstances, I thought it would be a good idea to resurrect it as a webinar. So this is me. My name is Ian Jones, and I'm a radiologist. I graduated from London in 2004, and I got my imaging certificate from the MRCVS in 2009. I did my residency again at the RVC between 2013 and 2016, and I finally got my European diploma in 2018. And you guys can find me at London Veterinary Specialists, which is a multidisciplinary referral hospital in the centre of London. So if I can be of any assistance with imaging interpretation, or if you'd just like a chat about which imaging modalities or which imaging tests might be most appropriate to use in a case that you're working up, then please give me a call or drop me a line via email. So today we're going to talk about patients presenting with acute abdominal signs. This is very loosely defined as patients presenting with these clinical signs. So vomiting, abdominal pain, anorexia, lethargy, or a combination of all four. And you guys, when you're presented with a patient such as this, might decide to do some abdominal radiographs. And having done the abdominal radiographs, the question that you most often want answered most urgently is, based on the radiographic changes that I can see and this patient's signalement, do I need to cut this animal? And so hopefully this presentation will help shed some light on how to make those sorts of decisions. So when we talk about how to use radiography to help us decide whether a patient has a surgical or a non-surgical problem, we are generally looking for specific conditions. And what we're going to do is we're going to split the abdomen into 4 separate regions and talk about the sorts of lesions you guys might encounter in those regions in patients presenting with an acute abdomen. We'll start by looking at the peritoneal and retroperitoneal space. And when we're looking at those structures, we're really looking to diagnose things like pneumoperitoneum, the presence of peritoneal effusion, and/or a peritonitis. We'll look a little bit at the stomach, and we'll talk about how we can confidently diagnose GDVs, so gastric dilation and volvulus, and gastric foreign bodies. We'll also spend a bit of time looking at the small bowel, and most commonly we'll be trying to decide whether or not a patient has a mechanical ileus secondary to a foreign body or some other obstructive lesion like a linear foreign body. And then finally, we'll take a very brief look at the large intestine and talk about colonic torsion. Not something that we see very often, but we need to know how to recognize it, because if it's there, then that is a surgical condition and that patient is going to need to be cut. So to begin with, let's talk about the peritoneal space. The peritoneum, very broadly, is made up of 3 component parts, so the parietal, the visceral, and the connecting peritoneum. The parietal peritoneum is that part of the peritoneum that covers the abdominal cavity. The visceral peritoneum is the peritoneum that is covering the abdominal organs, and then the connecting peritoneum is the peritoneum between the two, the mesentery and the omentum. When we're looking to diagnose a pneumoperitoneum, effectively what we're looking for is any evidence of gas within the peritoneal cavity. And that usually manifests itself as an increase in contrast and is usually due to internal air escaping into the peritoneal cavity, so internal air popping out, and that's usually as a result of a primary gastrointestinal problem, so a GI perforation, either secondary to, say, a gastric or a duodenal ulcer, or maybe a foreign body, or external air getting in, and that's usually due to wounds, or potentially it could be because that patient has had an exploratory laparotomy recently. And this is what it tends to look like. So this is a lateral radiograph of a dog's abdomen immediately after a laparotomy. And we can see that the gas has accumulated in the cranial dorsal abdomen, and we've got an increase in contrast, which is nicely outlining the margins of the diaphragmatic crura, the edges of the liver, and also the edges of the kidneys. Now, in this patient, it's not too difficult to see the gas that's accumulated in the abdomen, but it can be pretty tricky at times to pick up changes compatible with the pneumoperitoneum, particularly in patients that have other comorbidities. So if a patient has a very small volume of gas and it has maybe a peritoneal effusion and also a peritonitis, and maybe a very gassy gastrointestinal system, it can be pretty tricky to be confident about there being gas within the peritoneal cavity. And there are a few things that we can do to make it easier to spot gas within the peritoneal cavity. So there are a couple of techniques involving a horizontal beam that can make it easier to diagnose a pneumoperitoneum. The first is with the patient in dorsal recumbency, and it's effectively a lateral view. In order to increase the chances of picking up the gas in the peritoneal cavity, you can also elevate the cranial abdomen, and just as in the previous radiograph that we've reviewed, we're still looking for gas between the liver, the diaphragm, and the ventral abdominal wall. So if you guys are struggling to visualize what this might look like, so a horizontal beam technique, it's a lateral view with the patient in dorsal recumbency. It looks a little bit like this. So you can see the patient has been placed on its back. So in dorsal recumbency, we've used a little foam wedge just to elevate the cranial abdomen, and we're using a horizontal beam technique. So our tube is positioned adjacent to the patient, and our cassette just opposite it. So the primary beam is passing from left lateral to right lateral. So this is a lateral view with the patient in dorsal recumbency using a horizontal beam technique. And using this technique, it can be a lot easier to see small volumes of gas within the peritoneal cavity. And if you guys go ahead and try and take a radiograph like this, if you have a patient that has gas in its peritoneal cavity, then you should end up with something a little bit like this. So this is a lateral horizontal beam radiograph taken with the patient in dorsal recumbency. You can see we've elevated the cranial abdomen, and we've got gas within the ventral and cranial abdomen here, increasing the contrast and outlining the margins of the diaphragmatic crura and the ventral borders of the liver. So that's a technique that you guys can try if you're struggling to diagnose a pneumoperitoneum in a patient where you're highly suspicious there could potentially be, say, a septic peritonitis, a GI perforation, anything that might require surgical intervention. There is another technique using a horizontal beam, which is acquiring a ventrodorsal view with the patient in left lateral recumbency. And in this view, once you've acquired your image, you're looking for gas underneath the abdominal wall adjacent to the ribs. And again, it can be tricky to try and visualize what this might look like. And it looks a little bit like this. So this patient is in left lateral recumbency, and we have the tube just adjacent to the ventral aspect of the patient, and then the cassette positioned just next to the patient, opposite the tube on the ventral, on the dorsal aspect of the patient, and then we've got the primary beam passing from ventral to dorsal. So effectively, this is a VD view acquired using a horizontal beam technique with the patient in left lateral recumbency. And it's important to have the patient in left lateral recumbency using this technique, because if you use a right lateral recumbent patient, it's often easy to get gas within the peritoneal cavity confused with gas within the gastric lumen. So if you find yourself in a situation where you feel you might want to try this to diagnose a pneumoperitoneum, make sure it's a left lateral that you acquire rather than a right lateral. And if you go ahead and acquire one of these images, it should look a little bit like this. And in this image, we can see that we've got a gas lucency just underneath the abdominal wall, just highlighting the margins of the adjacent viscera. And this patient, like the one before and the one before that, has a pneumoperitoneum. So this is an alternative horizontal beam technique. This is a ventrodorsal view acquired with the patient in left lateral recumbency. So if you have a patient and you've taken your standard views and you're suspicious that there might be a pneumoperitoneum and you might need to go in surgically to investigate what the cause of that pneumoperitoneum might be, but you're not entirely sure because it's pretty tricky to decide whether or not that gas that you can see in those standard views is within the gastrointestinal system or is in fact just free within the peritoneal cavity, then consider using one of these horizontal views. You do need to have a tube that you can move. So I know there's a lot of practices where you're not able to move the tube in such a way that it's possible to use these horizontal techniques. But if it is possible, then it's worth a go. They can be really useful when diagnosing a pneumoperitoneum. So moving from the peritoneal space to the retroperitoneal space, the retroperitoneal space is effectively the space between the dorsal margin of the parietal peritoneum and the abdominal wall, and contains the kidneys, the ureters, and then a whole bunch of blood vessels and lymph nodes. It has both a cranial and a caudal communication. Its cranial communication is with the mediastinum, and its caudal communication is with the pelvic canal. So here's an example of a patient with a pneumoretroperitoneum. So we can see that the radiopacity of the retroperitoneal space is quite mottled and is made up of gas lucency, not gas bubbles, because they're not really discrete enough to call them bubbles, but a mottled gas lucency within the peritoneal space, effacement of the margins of the structures that normally reside within the peritoneal space, and overall an increase in opacity. So that's what a pneumoretroperitoneum looks like. Commonly, this can occur secondary to a pneumomediastinum. So the retroperitoneal space, as we said, communicates cranially with the mediastinum. If you have gas within the mediastinum, then you can have gas tracking from the mediastinum into the retroperitoneal space. So that's an example of a pneumoretroperitoneum. This is an example of another patient with an abnormal retroperitoneal space. In this case, we've got a more uniform increase in opacity of that retroperitoneal space. And it's much easier to see if we compare the opacity of this retroperitoneal space to the opacity of the peritoneal space. So in the peritoneum, we have got good serosal detail, so we can still see the margins of the liver. It's very easy for us to see the margins of some of the small bowel and large bowel, and you can see the bladder as well. In the retroperitoneal space, the detail is nowhere near as good. We've got some effacement of the margins of the kidneys. So there's something going on in this retroperitoneal space that is causing that increase in opacity and the effacement of the margins of those organs. And this is a dog that had eaten rodenticide. So this is a dog that was actively bleeding into its retroperitoneal space. So we've got fluid accumulating in this retroperitoneal space, which is causing that increase in opacity and the effacement of the margins of these kidneys. And that brings us on nicely to peritonitis and peritoneal effusion. So in that last case, we were talking a little bit about the loss of contrast in the retroperitoneal space as a result of bleeding secondary to rodenticide, and that's pretty typical for an effusion or a peritonitis within the retroperitoneal space or the peritoneal space. So patients that have peritonitis and peritoneal effusion, the serosal detail will be very poor. So we won't be able to see the margins of all those abdominal organs. So it's going to be tricky for us to see the margins of the liver, the urinary bladder, and to make out different segments of small bowel. Occasionally, neoplastic conditions can cause a loss of serosal detail. So you might have a patient that has, say, a carcinomatosis or a lymphomatosis that can result in a loss of peritoneal serosal detail, but almost invariably there'll be a degree of peritonitis and peritoneal effusion there as well. You can sometimes see this in very thin dogs. So if a dog or a cat has very little intra-abdominal fat, then that can result in a loss of peritoneal serosal detail, or in a very young patient. So young patients have a lot of brown fat within their abdomen, which has a different density to normal fat, and as a result of that, they have very poor peritoneal serosal detail, even if they're normal and there's nothing to worry about in that abdomen. So very thin patients, very young patients are going to have poor peritoneal serosal detail. Other than that, if you are looking at an abdominal radiograph and you're really struggling to see any of the organs, then you certainly need to consider the presence of a peritoneal effusion and or a peritonitis. So this is an abdominal radiograph of a cat with a large volume of peritoneal effusion. And we can see that there's a homogeneous soft tissue opacity distributed uniformly throughout this abdomen, which is also very distended. So if we look at the margins of the ventral abdomen, it's very convex in shape. So we've got very poor peritoneal serosal detail because of all this peritoneal effusion. It's impossible for us to make out the margins of any of those abdominal organs. We can't see the liver, we can't see the spleen, we can't see the urinary bladder, the kidneys are also not visible, and that's most likely due to superimposition of the peritoneal effusion on the retroperitoneal space. Doesn't necessarily mean that there's fluid within the retroperitoneal as well as the peritoneal space. We can still see a little bit of gas in the stomach and in some of the large bowel and small bowel. We've got this other lesion here, which looks quite discrete and mineralized. Difficult to know exactly what that is at this point, but certainly a loss of peritoneal serosal detail throughout this abdomen compatible with a large volume peritoneal effusion and or a peritonitis. So this is another example of a patient with peritoneal fluid. This is a dog, and it's a little bit tougher to see in this patient relative to the cat that we looked at previously. But hopefully you guys can appreciate that the serosal detail here isn't anywhere near as good as it should be. So we can still make out little radiopacities throughout the abdomen, but it's very difficult for us to get a good handle on exactly where the margins of the organs are. And uniformly, the opacity looks a little bit mottled and a little bit fuzzy. So this is definitely a patient with reduced peritoneal serosal detail, and that would be compatible with either a peritonitis or a peritoneal effusion, or both. But this one a little bit more subtle than the previous. Moving on to the stomach. So a GDV, a gastric dilation involvus, is not something that many of us look forward to, particularly if we're on call and it's a Friday night. If you have a patient that you suspect has a GDV, and typically these are larger dogs, they might have had a large meal just before the owners have called the practice to say that their dog is now looking quite bloated and unproductively retching. So if you have a patient that you think might have a GDV, then a right lateral radiograph is certainly the way to go. And you can diagnose a GDV very confidently with just a right lateral radiograph. You don't necessarily need to get into doing VDs. Oftentimes that's not necessary. And the GDV, the twisted stomach, the volvulus, is due to the pylorus moving cranially, dorsally, and to the left in a clockwise direction. And that's if you look at the patient from a caudal position. So effectively, you're standing behind the patient and watching the pylorus move in a clockwise direction, dorsally and to the left. So it's going to go clockwise. It's going to go sort of ventral to dorsal from right to left. And because of that, it's going to end up in a very abnormal location. It's going to end up on the left. The fundus is going to end up on the right. And because the spleen is attached to the stomach, then the spleen is going to move with the stomach, and then the spleen is going to end up on the right as well. So this is the sort of radiograph that we don't really want to see if it's 11 p.m. on a Friday night and we're on call. So this is a right lateral radiograph of a 5-year-old male neutered Rhodesian Ridgeback that's presented with an acute onset of unproductive retching and looking bloated. And what we can see is that the stomach is grossly dilated with fluid and gas. So we've got this fluid or sort of soft tissue opacity centrally, and that's surrounded by these compartments of gas lucency. We can see that the stomach looks like it's made up by 3 compartments, and you sometimes hear people use the word compartmentalization when they're describing the changes associated with a GDV, and that's what it's referring to, these soft tissue bands that are bisecting the stomach. When we are confidently diagnosing a GDV, we need to be able to identify the pylorus and be sure that the pylorus is in an abnormal location. And the pylorus is usually more tubular and narrower than the rest of the stomach. And in this dog, this is the pylorus here, and it's in a very abnormal location. So normally the pylorus should be positioned ventrally down here, and in this dog, it's positioned in a dorsal location. Another term that I've heard people use to describe these changes is a double bubble sign. So we've got sort of one bubble here and then one bubble here. I often think of it as like Popeye's arm. So if you guys remember Popeye the sailor, then this is Popeye's hand, and this is Popeye's forearm, where there should be a little anchor, and this is his bicep. So if you see Popeye's arm and Popeye flexing his muscles, then you can be pretty confident that you're looking at a GDV, and that this is the pylorus. It's in a dorsal location, it's in an abnormal location, that stomach is twisted, and this patient needs surgery in order to correct it. Now, as well as being confident about the position of the pylorus, there's a few other things that we should be looking out for in these patients with GDVs. We can look for the presence of gastric pneumatosis, which is gas permeating the stomach wall, the presence of a splenic torsion. So as we said before, as the stomach moves around, it takes the spleen with it. So the spleen is usually in an abnormal location and can get torsed. So it's worth looking at and commenting on the position and the appearance of the spleen. A lot of these dogs are hypovolemic because the dilated stomach is going to reduce blood flow to the heart by compressing the caudal vena cava. They quite often have evidence of a paralytic ileus and an esophageal dilation. So if you do see lots of dilated loops of small bowel, you're thinking, could this patient really have a GDV and potentially have a mechanical ileus? It's not that there's a concurrent mechanical ileus, it's that a lot of these dogs also have a concurrent paralytic ileus. So don't let that confuse things. These are some images taken from a paper that was published back in 2004, and they demonstrate gastric pneumatosis. So we've got a right lateral view in A of a patient with a GDV. Again, we can see the narrower, more tubular pylorus in the dorsal location, so in a very abnormal location. So if the pylorus is in a dorsal location, then the stomach must be twisted. Not quite as beautiful a Popeye arm as we had in the previous case, but still we can see this is Popeye's bicep and this is his hand. So we're pretty confident that the stomach is twisted. As well as that, we've got some strange gastric contents. So this patient has eaten a whole bunch of mineralized material before twisting the stomach. We've got this paralytic ileus that we talked about. So we've got a single population of small bowel that is moderately dilated and filled with gas. And then if we zoom in on the stomach wall, we can see that we've got a little linear band of gas within the stomach wall, and that is compatible with a gastric pneumatosis. Now, the reason why we need to watch out for changes compatible with the gastric pneumatosis is that the presence of air within the gastric wall, so a gastric pneumatosis, very specific for predicting gastric necrosis. So the specificity that was quoted in this paper is 92.7%. So if you see these changes, if you see evidence of gas permeating the gastric wall of a gastric pneumatosis, then chances are that patient has gastric necrosis as well as its twisted stomach, and has a poorer prognosis. So the presence of gastric pneumatosis, very specific for the presence of gastric necrosis, which is a negative prognostic indicator. So it's worth looking for that because it might aid you in deciding what to do next in terms of whether to take this patient to surgery or not. So don't forget to have a good look at the stomach wall and make sure there aren't any radiographic changes compatible with gastric pneumatosis, because you might not get a horrible surprise when you open a patient and find that its stomach wall is completely necrotic. So, moving on from GDVs, let's talk a little bit about gastric foreign bodies. Radiographically, gastric foreign bodies typically appear as just persistent radiopaque material. Foreign bodies, not all of them, but a lot of them are going to be radiopaque, and they're going to just sit in the stomach. So if you take a series of radiographs, these structures are not going to move out of the stomach. And usually, if they're going to cause problems, then they're going to be big, and potentially they're going to get stuck in the gastric outflow tract. So this is a case report of a very novel gastric foreign body, one that I thought I'd share with you. So we've got a right lateral radiograph. This is a 2-year-old mixed breed dog that has a gastric foreign body. So the stomach is hugely dilated, and it's filled with this material that has a very heterogeneous, very mixed, very mottled radiopacity. And difficult to know how this patient managed to eat such a large foreign body until, when questioning the owner, you find out that this dog has actually been seen eating wood glue. So wood glue rapidly expands following ingestion, and apparently can taste quite sweet, which is why dogs can sometimes eat it. So they eat this wood glue, which is a liquid, and then it rapidly expands in their stomach, creating just a big rock, a big boulder foreign body, which then needs to be removed. So that's a nice example of a novel foreign body that hopefully you guys won't forget. So the small intestine is often something that we spend a lot of time looking at when we have patients presenting with an acute abdomen and we're trying to decide whether to cut them or not. And most of the time, we're trying to decide whether we can see a foreign body and or there is sufficient evidence of a mechanical ileus to justify surgical intervention. So for patients like this, where we're looking to try and diagnose a foreign body or a mechanical ileus, I'd recommend that you take 3 views, so a left lateral initially, then a ventrodorsal, then a right lateral view. And that's because if you take the left lateral initially, then the gas that's in the gastrointestinal system is going to go to the non-dependent part of the abdomen. So it's going to go into the pylorus and potentially the duodenum. So when you then roll the dog from left lateral to ventrodorsal, you're more likely to have gas within the pylorus and the duodenum during the ventrodorsal view and also the subsequent right lateral view. And if you have a foreign body that is either stuck in the pylorus or is in the duodenum or in the jejunum, then you're much more likely to see it if it's being outlined by gas rather than fluid and ingesta. Here's an example of a case where taking 3 views really helped to make the diagnosis. So we've got a left lateral radiograph initially, then we've got a VD, and we've got a right lateral. Now, in the left lateral radiograph, we can see that we have the gas that's accumulated in the non-dependent part of the abdomen, so in the pylorus, and this gas has outlined a clearly marginated, mottled radiopaque structure that looks like it is lodged within the gastric outflow tract. So we've got this structure here, which is very abnormal. That shouldn't be there. That is most likely a foreign body, and it looks as if it's extending into the duodenum. Now, the reason why it's easier for us to see this structure is because it's outlined by gas. So because we've taken the left lateral first, we've got a whole bunch of gas in the pylorus, and we can see this foreign body that's stuck in the gastric outflow tract and extending into the duodenum very easily. On the VD view, it's pretty tricky to see. We've got this loop of bowel that's filled with gas in the right cranial abdomen. That could potentially be the cecum. And then we've got a few other little loops of bowel in the right cranial abdomen, but pretty hard to see the foreign body in that view. And then in the right lateral view, we've got this mottled radiopacity in the cranioventral abdomen, which could absolutely represent foreign material within the small bowel and potentially within the duodenum, but it's much harder to see. In this left lateral view, there is absolutely no doubt that there's a foreign body there, and not only that, but there's a foreign body that is stuck in the pylorus, and that this patient has a gastric outflow tract obstruction. So what I'd like you guys to take away from this is that if you are working up a patient for a suspected foreign body, then I'd take 3 views in this order: left lateral, VD, right lateral, and that's going to maximize your chances of outlining the foreign body if it's in the stomach or the duodenum with gas, and make it much easier to see. So if we're not able to see the foreign body, then we need to look at some of the other structures to try and decide whether this patient is obstructed, has a mechanical ileus, and needs to be cut. And the sorts of things that we're looking for are, can we see 2 distinct populations of small bowel? So is there one population of small bowel that is very dilated, another population of small bowel that is really empty? And the reason why we'd see 2 populations of small bowel in a dog that is obstructed is because the ORAD bowel relative to the foreign body, so the bowel that's closer to the mouth, that's going to be massively dilated because it's not able to push the ingesta past the foreign body. And the bowel that's aborad relative to the foreign structure, that's going to be really empty because no ingesta can get to it because it's getting blocked by the presence of a foreign body within the small intestinal lumen. So if you see 2 distinct populations of small bowel, that's really compatible and indicative of a mechanical ileus secondary to a foreign body. Oftentimes, if you have really dilated loops of bowel ORAD to the foreign body, they can stack up. So you see loops of bowel, one on top of the other. Obviously, if you can actually see the foreign material, then that makes it easy. So, for example, if you have a dog that's eaten a stone and is obstructed, then you're going to be able to see the stone. So you don't really need to worry about looking at the populations of bowel and stacking and other changes like the presence of a reduction in serosal detail or a pneumoperitoneum because you can see the foreign structure. If you can't, it can be much more challenging. And if we're talking about these 2 populations of small bowel, one being dilated and one being empty, then the question is, well, how do I know if a piece of small bowel is dilated or not? And there's been a whole bunch of papers published in the last 10 years on this very subject, and all of them recommend slightly different objective measurements in terms of defining small intestinal dilatation. So the one that most people tend to go with is the one that's published in the textbook of veterinary diagnostic imaging by Thrall, and that suggests that if you see a loop of bowel that is greater than or equal to twice the width of a rib or greater than 1.6 times the height of L5, then that's sufficiently dilated for us to be concerned about a mechanical ileus. But there are a few papers that have been published a little bit more recently that suggest slightly different criteria. So one published in 2011 by Sharma suggests 2.2 times the height of L5. And we've got 2 other papers by Fink and Siaska that suggest 1.7 and 2.4. Excuse me, for me, I would use 1.6 times the height of L5, and essentially the bigger the bowel, the more likely it is to be obstructed. And that's a pretty good rule, I think, to go by when you're evaluating these abdominal radiographs and you're trying to decide whether these loops of bowel are too dilated. So 1.6 times the height of L5, if it's bigger than that, then you need to be suspicious. But broadly speaking, the bigger it is, the more worried you should be, the more likely it is that a patient is obstructed. So this is a lateral abdominal view of a dog that has a small bowel obstruction. So here we can see that there are definitely 2 distinct populations of small bowel. So we can see loops of bowel in the cranioventral abdomen and in the mid to dorsal abdomen that are very dilated. And we can see a population of small bowel in the mid to ventral abdomen that is looking a lot smaller and looking pretty empty. So we've got 2 distinct populations of small bowel. That's always a big worry. And then we've got stacking of these dilated loops of bowel in the cranioventral abdomen and in the mid and dorsal abdomen. We've also got some stacking excuse me, in the caudal dorsal abdomen. There's maybe a little bit of a loss of peritoneal serosal detail here as well. So the presence of these two distinct populations of small bowel, the fact that one of the populations is markedly dilated, and we've got stacking and actually displacement of some of the loops of small bowel here, mean we should be very suspicious for the presence of a mechanical ileus secondary to a foreign body. And if you have a patient that has an abdominal radiograph that looks like this, then it absolutely needs to go to surgery and have an X-lab. Here's another abdominal radiograph. This one is slightly different. So in this patient, we have a single population of small bowel, but that single population of bowel is quite markedly dilated. There's some evidence of some foreign material within the small intestinal lumen. So we've got a little metallic tack and some other mineralized material here. But we've not got two distinct populations of bowel, just a single very dilated population of bowel. It does look as if they're kind of stacked up, but all of the bowel is present in the mid-abdomen. And this is an example of a mesenteric volvulus. So this dog didn't have a foreign body, didn't have a mechanical ileus, it had a mesenteric volvulus, so the intestine was twisted at the root of the mesentery, resulting in ischemia and then gross dilation of all of the loops of the small bowel. So this is what a mesenteric volvulus looks like. So the other thing for us to talk about are linear foreign bodies. So linear foreign bodies tend to anchor in slightly different places in dogs and cats. So in dogs, typically they will anchor at the pylorus and extend into the duodenum, whereas in cats, they tend to anchor underneath the tongue. Now, whether it's a cat or a dog, whether it's anchored at the pylorus or underneath the tongue, you tend to get plication of the small bowel as a result of it. And plication of the bowel is really pathognomonic for the presence of a linear foreign body. And as a result of the plication, you tend to get a very distinctive streaky gas pattern. And that's what we need to be watching out for in a patient that we think might have a linear foreign body. So this is a right lateral abdominal radiograph of a dog that has a linear foreign body. We can see that the stomach contains soft tissue opaque material and gas, and also some foreign material as well. So there's some metallic structures present within the stomach and also within the small bowel. We can see that the small bowel is pretty bunched up in the middle of the abdomen here. So there's a big clump of it just right in the middle of the abdomen. Doesn't really seem to be anywhere else. And the conformation of the luminal gas within the small bowel is a little bit unusual. So if we take a closer look at that, one of the things that I want you guys to take away from this image is how the gas looks within the bowel in this patient with a linear foreign body. So you have focal areas of gas lucency that are almost comma-shaped, and you have lots of them, and that's the gas that is within the lumen of the small bowel that is all plicated and all concertinaed up. So if you see discrete, clearly marginated, comma-shaped areas of gas lucency, luminal gas lucency, and you see bunching of the small bowel in the middle of the abdomen, then you need to be very suspicious that that patient might have a linear foreign body. And oftentimes that in a dog, that linear foreign body could be anchored at the level of the pylorus. So like we said before, it's worth getting a left lateral view, a VD view, and a right lateral view to try and highlight that foreign body that might be anchored at the pylorus. So this patient had a linear foreign body. There's maybe also some loss of serosal detail here as well that tells you that there's something going on that really does need sorting out. So just a word of caution for cats. So we've got two radiographs here. They're both abdominal, and they both show the mid-abdomen and gas within the bowel The radiograph on the left is an obese cat, and what we're looking at are normal gas-filled loops of bowel. So in big fat cats, often the small bowel will bunch up in the center of the abdomen, and you can sometimes confuse that with a linear foreign body. So if you have a big cat and you have small bowel that's bunching in the center of the abdomen, but the gas within the lumen still looks normal, so we're still getting these linear loops of luminal gas, then that's a normal appearance. If you have an abdomen that looks more like the radiograph on the right, where you've got these focal discrete gas lucencies that are a little bit comma-shaped, then that's when you need to be concerned about a linear foreign body. So this is a cat that has a linear foreign body. It has discrete, focal, clearly marginated, comma-shaped intraluminal areas of small intestinal gas, and that's abnormal, and that's compatible with a linear foreign body. This is an obese cat that just has some bunching of small bowel within the mid-abdomen, and this is an incidental anatomic variant. These metallic opacities that we can see in this abdomen are just hemoclips secondary to previous ovary hysterectomy. So this is a radiograph of a cat, and what we can see here is a single loop of small bowel that looks quite dilated. Now, when we're looking at this radiograph for the first time, we might ask ourselves, well, the location of this dilated segment of bowel does lend itself more to maybe small bowel rather than large bowel, but how can we be absolutely sure? If this is indeed a dilated loop of small bowel, as we suspect, then that's dilated enough to warrant an exploratory laparotomy in this patient to investigate a possible obstruction and mechanical ileus. If this is just gas within the large bowel, then effectively that could be normal, and we could recommend surgery in this patient for no reason. So is there anything we can do to be more confident that this loop represents a dilated loop of small bowel rather than a loop of large bowel? And the answer is yep. So we could potentially do something called a pneumocolonogram. So a pneumocolonogram is essentially just the installation of air into the rectum and the descending colon. And once you've done that, it's much easier to confidently identify which bowel is large bowel and which bowel is small bowel. And it's very easy to do, and patients do need to be quite heavily sedated or anesthetized in order for you to do this. However, you just need a small balloon-tipped catheter. You inject a little bit of air, so roughly 8 mils per kilogram, but do it very slowly. And obviously, if you get a lot of resistance, then stop. And after instilling the air into the colon, you then take lateral and ventrodorsal radiographs. And that's what was done in this cat. So we've picked up on this single dilated loop of bowel. We've just questioned, well, is this definitely small bowel, or could that be large bowel? And then we've injected some gas into the rectum and colon, and that's now highlighted beautifully. And we can see that we've got a fairly empty descending colon, and that this dilated loop of bowel is nowhere near that. So this absolutely is a markedly dilated loop of small bowel. It's definitely not large bowel, and we can now be super confident in recommending surgery for this patient. So just to make you guys aware of pneumoclonograms and just how useful they can be. And that brings us nicely onto the large bowel, and something that is not too common, but these patients with colonic torsion, they are out there, and it's certainly worth knowing what to look for, just in case you come across one. So colonic torsion typically occurs in large breed dogs. The radiographic change that you're really looking for is displacement of the cecum. So the cecum will be on the wrong side, so it'll be on the left rather than on the right. And You'll also see segmental dilatation of the colon, so the colon will be really big and full of gas. The descending colon typically will narrow quite abruptly and can also be quite markedly displaced. So here's some radiographs of a dog with a colonic torsion. This was taken from a paper that was published fairly recently in VRU. If we look at the VD view first, we can see that the cecum is on the wrong side. So we can see the cecum labeled CE is on the left rather than on the right, and the descending colon is on the right rather than the left. So the descending colon and cecum have swapped positions, so immediately we should be thinking that this patient has a colonic torsion. And then looking at the lateral view, we can see that there's quite abrupt narrowing of the descending colon, and we've got associated segmental dilatation of the descending colon and the cecum as well. So if we see this combination of changes, the cecum and the descending colon on the wrong side, so the cecum on the left, the descending colon on the right, we've got abrupt narrowing of the colon and then segmental dilatation of the descending and potentially transverse and ascending colons. Then we're confident that this patient has a colonic torsion and it needs to have an exploratory laparotomy. Now, invariably, not all patients with colonic torsion have changes that are as easy to see as this, and sometimes there is reasonable doubt as to whether or not a patient has a colonic torsion. And in those instances, we can do a barium enema. So just like the pneumocolonogram, in order for patients to tolerate this, they really need to be either sedated or anesthetized. Again, using a small balloon-tipped catheter, you can pop that into the rectum and then instill just a small amount of barium suspension, so around 5 mils per kg. And again, do that very slowly. And if you come across any pressure, then stop. And what you should see in a patient that has a colonic torsion is longitudinal helical striations, and those are easier to see in the lateral view than in the VD view. So this is the point where we were seeing the abrupt narrowing of the descending colon, and here we've got these beautiful longitudinal helical striations that's called a torsion sign. So if you see these changes, so these longitudinal helical striations and abrupt narrowing, that's following a barium enema. That's pretty pathognomonic for a colonic torsion, and you can be absolutely certain about your diagnosis and be confident about your recommendation of an exploratory laparotomy. So this is a torsion sign secondary to a colonic torsion in a patient that's been given a barium enema. And these are all things that you can do in first opinion practice. Okay, so that's colonic torsion. So I thought we'd just finish on just a clinical case. And this is a 5-year-old male-neutered cane terrier that presents to you with a history of vomiting. And we've got 2 radiographs to look at. We've got a right lateral radiograph and a ventrodorsal radiograph. And immediately we can see that there's quite a large, clearly marginated, opaque structure within the mid-abdomen in the right lateral view, and within the right cranial abdomen in the VD view. And we've also got some dilatation of the small bowel. So it's gas-filled. It isn't too big. It's certainly not so big that we would potentially be thinking about diagnosing this dog with a mechanical ileus just on the strength of the size of that small bowel. So a few little loops of bowel that contain gas. These loops of bowel, they are a little bit bigger than some of the other loops of bowel. So technically there could be 2 different populations of small bowel here. Although the population that's dilated, it's not really too dilated, and I'm not able to objectively compare the width of the small intestinal lumen to the height of L5 here, but I'd be confident to say that's not so dilated that we could diagnose a mechanical ileus secondary to that. The peritoneal serosal detail is pretty good. I can still see all of these abdominal organs pretty well, and so I'm not really too concerned about either a peritonitis or a peritoneal effusion. The question is, if this structure here, it's so big, it would be be pretty surprising if this thing could go all the way from the stomach all the way to the colon without causing an obstruction. But I don't really see sufficient radiographic changes here to absolutely recommend an exploratory laparotomy. So what else could we do? Well, it could be that this structure is within the colon rather than in the small bowel, and if that's true, then a pneumocolonogram might help, or we could potentially do an abdominal ultrasound. That also might help. But we're just in first opinion practice, and we've just got these radiographs. So the question is, well, do we cut it or not? And I don't necessarily think there's enough there for us to cut it without doing something additional. And like I said, you could potentially do a pneumocolonogram or an ultrasound. And in this patient, we did an ultrasound, and that structure was actually present within the duodenum. This is the duodenum just here, so we can see the different layers of the duodenum. And this is the lumen, this is the mucosa, and we've got this quite large, quite clearly marginated, hyperechoic structure that's strongly shadowing within the duodenal lumen. So this is a duodenal foreign body, and the reason why we're not seeing marked dilatation of the small bowel is because it's so far up. So it's in the duodenum, and this dog is vomiting. So because the dog's vomiting, all of the ingesta that's accumulating in the duodenum and the stomach, it's all getting vomited up. So we're not really seeing any changes compatible with mechanical ileus because of where this foreign body is, because it's in the duodenum. So this dog did go to surgery, and this foreign body turned out to be a big part of a tennis ball. So there we go. So hopefully you guys enjoyed this webinar. If you have any questions, then give me a call or send me an email. And yeah, I will see you all again for some more webinars in the future. Stay safe, and thank you very much for your attention.